Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Heather Finlay-Morreale. She's a pediatrician. Her KevinMD article is titled, Having More Doctors to Assess Rare Multi-System Illnesses. Heather, welcome to the show.
Thanks for having me. Nice to be here.
We'll get into your article in a little bit, but first off, briefly share your story and journey to where you are today.
I came into medicine a little late. I started medical school at 30 after doing some other career avenues. I come from a non-medical family, so I was the first one to kind of forge ahead in this area. I did a lot of writing in med school, actually, and had some success with different contests and publications. And then my writing went dormant through PEDS residency at Tufts. And then once I was in attending at UMass, I kind of picked up the pen again and have found writing really helps me to kind of process what's going on, express my thoughts and feelings. And it's been a real outlet for me. And then a couple of years ago, I got sick, first with autoimmune small fiber neuropathy, followed by myasthenia gravis. And since then, most of my writing and advocacy is really based on kind of the diagnostic odyssey that patients go through and experiences patients can have with physicians.
Yeah, so tell us about that odyssey a little bit. What are some things that you've learned? What are some things that surprised you during that odyssey?
Well, surprisingly, even though myasthenia is in, every board exam you ever take ever, Addison's and several other rare diseases, because it's rare, I think a lot of doctors think nobody has it. So when you're sitting in front of them, they'll say, wow, this could be myasthenia, but it's so rare, I'm sure you don't have it. And I heard another doctor say, zebras are zebras, but they're not unicorns. There are, in fact, actual zebras out there. And so, any given doctor is going to find a patient with a rare disease at some point in their career. But what happened is both the small fiber and the myasthenia kind of hit multiple organ systems. And you kind of learn as a doctor when a patient comes in with complaints in all kinds of organ systems and you don't know what the answer is. Because of course, you're the doctor, you're the smartest in the room, you should know the answer. And if you don't know the answer, then it's psychosomatic. And so even as a doctor, it took 2 years to get my myasthenia diagnosis, despite being really symptomatic for a long time.
So tell us about your interactions with the healthcare system. You said it took 2 years before pinning down that myasthenia diagnosis. Tell us about those healthcare interactions during that time.
Yeah, well, I would go to different specialists. I'd go to cardiology and they'd say, oh, well, you have this cardiac thing or you have this cardiac thing. And then GI would see their little aspect of it. And each specialty sees its own little tiny silo. And there's no one to really put the whole picture together. I mean, luckily, I myself was able to put the whole picture together and then, find specialists in that diagnosis. But most people don't have that opportunity. And there's a lot of patients with multi-system illnesses that are really struggling to find someone to kind of pull all the pieces together. And if it took me 2 years with the best healthcare options possible, I can really see why a lot of people with autoimmune diseases take 5, 6, 7, 8, 9, 10 years. And for the really rare diseases, diagnostic odyssey can be decades.
Now, was there a primary care physician who could help you pull these things together?
Not really. Once you get to be a certain amount of complexity, it's kind of like a hands-off kind of thing with the primary cares, I think. So no, not really.
So tell us about the path that actually led up to that diagnosis. So who actually made that diagnosis, 2 years of this journey?
Yeah, interestingly, so I had hired some help at home, some PCAs, and one of them was a 4th-year med student who was in a in between time in her training. And I was asked to just film my eyes at the end of the day, because I would always talk about how at the end of the day I had blurred vision. So she did, the whole eye exam on my phone. And then she just said, whoa, you have some serious googly eyes. I guess they just kind of, went all around. And that was actually the clincher. And then once my optometrist saw the video, he said, do you think this could be myasthenia? And so in the end, it was actually the optometrist who first brought up the diagnosis. And then once that was brought up, my neurologist, I had more than one, just kind of went, oh, check. Actually, it explains everything. So it was just this tiny, odd event that led to it.
So after a couple of years of seeing all the specialists, it was actually a medical student who was working with you who kind of was a tipping point in terms of making that diagnosis.
Yep. Shout out to Daria Santoro. She's a great PEDS resident right now.
Now, for those who aren't familiar with what myasthenia is, just give us a brief overview of what that is.
So it's a muscle weakness disease. It's how the nerve communicates to the muscle, but acetylcholine doesn't work. And so at the end of the day, I have like a little acetylcholine bucket. And by the end of the day, it's all used up and I can't use my muscles. And in my case, it's most severe in my breathing muscles. And so when I get really weak, I can't breathe. It's kind of like being suffocated, actually. And at the very beginning of this odyssey, I actually was at the ER in a myasthenic crisis, and they thought I was faking. And I actually almost died.
So what is a myasthenia crisis?
If all your muscles get so weak and then at one point you can't really breathe, your diaphragm just stops breathing because you're tired. So I went apneic a couple times in the waiting room and passed out, actually, because I just was too fatigued to keep using my breathing muscles. So yeah, that's a myasthenic crisis.
So you've learned a lot during your journey to the diagnosis of myasthenia gravis, and you talk a little bit more about this in your KevinMD article, having more doctors to assess rare multi-system illnesses. So tell us, how did this article come together?
It was kind of percolating for a while. And then, I'd go to all these different doctors and have this laundry list of problems. My problem list just kept going bigger and bigger, but with no overall answer. And then I think once I finally had an answer, I have a very short problem list now. And I get treated entirely different in the medical system.
How so?
Because then you have a something that's in a textbook. You're interesting. And being interesting is a lot different than, I think, when patients see a patient come in with a long problem list and a long med list and no overall explanation. You kind of just get the, oh, someone is weak and dizzy all over. Oh my God, yet again. It's a totally different reaction. I got a complete U-turn in how I was treated with new physicians.
So give us an example of that, a complete U-turn. Like, would their demeanor change? Would the tenor of the visit change? How was it different?
Yeah. Well, at the time when I was at the ER in the myasthenic crisis, they told me that ERs can't solve all people's problems. Sometimes you have to go home and solve your own problem.
The ER
and my problem was I was suffocating to death. Yeah. And so, now when I go, myasthenia is on the top of my problem list. They do the respiratory therapist to come do the test to see how my breathing is. So I'm believed that something serious could actually be going on when I have trouble breathing. So it's entirely different experience.
What does it say about our healthcare system that people with kind of these long journeys to a diagnosis, complex multi-system diseases, have to see all these doctors, but oftentimes don't have an answer? What does that say about our healthcare system?
I think the silos are not helpful, that each specialist kind of knows about their own little tiny geographic area. I don't know a solution to that. I do think there's a little bit of, a lot of these multi-system illnesses are autoimmune illnesses, which predominantly affect women. I think there's a history of not listening to women who are in pain or women who are tired and have a lot of different multi-system complaints. And so I think it just gets shoved to the side. So I think that might be behind a little bit of the ignoring of this kind of illness.
And for those patients who may be undergoing that journey that you went, what kind of advice do you have for them?
It's hard right now because a lot of the community that has been connecting is on Twitter. There's a really large undiagnosed community on Twitter. And I mean, imminently, it seems like Twitter might just go away. And so there's a bit of a struggle because there's a lot of crowdsourcing, sharing doctors who are helpful's names, Facebook groups that also serve this population. The internet has really helped people to make connections and get diagnoses.
So on Twitter, what will be the hashtag for this?
There's one which is NEIS void, which is no end in sight void. There's also disabled, sometimes used, chronic illness, and then the specific diagnoses like POTS or long COVID, things like that.
Yeah.
So yeah, it's a really vibrant community.
Unfamiliar with what POTS is? What is that?
Postural orthostatic tachycardia syndrome. A large number of people with long COVID actually have that. I have it from my small fiber neuropathy, and it can affect multiple different systems and can present, if you're not aware of the diagnosis, might seem like a panic attack when in essence it's a heart abnormality.
So this group of patients, because of their frustration with the healthcare system and the lack of a potential diagnosis, goes on Twitter. What would some of those discussions be like?
There's a lot of talk right now in the long COVID community about clots, microclots, and there's a couple labs in particular that are also in the discussion. Just this week, one of the labs from Europe came over to Harvard and taught the Harvard doctors how to look for microclots. And some of the biggest voices on Twitter for long COVID went to Harvard and got their blood tested for microclots and then shared their discoveries. People are testing different supplements for long COVID and POTS, sharing their experience with that. There's a really common treatment called low dose naloxone, which has been pretty successful for autoimmune neurotype illnesses. So people share their experiences with that. Things that your average PCP hasn't heard of because they're really pretty cutting edge.
Anything else patients can do to help with their diagnostic journey? Any specific questions that they could ask when they interact with the healthcare system?
I think one thing I tend to think is doctors want to see something in a lab or something on a physical exam. And so I usually tell people to focus on whatever symptom of yours can be seen physically or on a lab test. Because if you kind of go in with, I'm really tired, even if that's your worst symptom, you're not likely to be super successful in getting help for it. But if you say, like in my case, I have blurred vision and double vision at the end of the day, that would kind of clinch the deal. That's something they can test. So go with kind of the more objective or unusual or like really discrete findings first, because that may be the clue to the overall illness.
Now, in an ideal world, it would be the primary care physician, whether it's a family physician, internal medicine physician, who would pull all this information from all the specialists and hopefully come up with a unifying diagnosis. Obviously, that's an ideal world. But what kind of advice do you have for us when we encounter patients without a clear diagnosis, have seen multiple specialists? What kind of questions can we ask these patients to become better in the exam room?
I think one thing that is hugely helpful is just validating the patient and listening that what is happening is real and that there is something wrong. You might not know the name of it yet, you might not have a treatment yet, but they're not making it up and it's not in their head. And that alone is hugely helpful.
What would be some things that you would hear physicians say that would invalidate a patient's complaints?
I heard in a group just today that they were told, well, you're a woman and all women get fat and tired as they age. So that would be an example of what not to say.
So there was someone in a group who had a physician say that to them?
Yes.
Anything
which
else?
is not helpful. Yeah, I think if you're starting to get a little bit weary in general of just patient after patient, I mean, it's a rough time right now. When you kind of go into the room, even if you've seen this patient many times before, just kind of wipe the slate and have an open mind when you go in and just listen curiously. And you may hear something different or put something together that you didn't the other 2, 4, 5, 6 times you've seen that patient. So kind of really go in open-minded without any, groaning or negative feelings you might have, and just really listen to the patient and then believe what they say. And then think about it. If you need to, ask the attendee or attending. And then you can still help a patient even if they don't have a diagnosis. If they're really nauseous, you could treat that. If their thyroid is off, you can treat that. You may not necessarily know the ultimate explanation for everything to be able to help with the tools that you have.
Now, you mentioned earlier that a lot of your work now is in the advocacy space for rare multi-system illnesses. So tell us about some of the work you're doing.
I worked a little bit on one of the capital advocacy days for the Muscular Dystrophy Association. And then I'm also working with the medical school here at UMass, specifically integrating content on the disabled into the regular curriculum, rather than having here's one day you learn about everything about disability, kind of as the students go along, learning about the different variants of normal. And so that's something I've been really involved in. And, it's kind of shocking for an occupation focused on sick people, how little we're taught about disability.
So what are some of the things that you teach these medical students?
Well, always listen and believe, and that usually patients with disabilities know more about their disability perhaps than you do. Really basic things like not making assumptions. When you go into the room and someone's in a wheelchair and has like an augmented communication device, don't assume that they're not mentally competent to take care of their own care. Don't assume that they're not sexually active. Don't assume that they don't smoke. There's a lot of assumptions that happen. I mean, if you see Stephen Hawking in a wheelchair, he's not doing his own ADLs, but he got a Nobel. So same thing, wipe the slate and come in with no preconceived ideas.
And what kind of resources can physicians turn to if we want to learn more about this?
It's a little limited, but actually the New Hampshire Department of Public Health has a really great, short and interesting video on working with disabled patients. And they have a short clip of an exam room encounter gone horribly wrong. It's just a train wreck. And then they have another clip of how to do it right. And it's short, it's helpful. You get CEUs. It's great.
We're talking to Heather Finlay-Morreale. She's a pediatrician, and her KevinMD article is titled Having More Doctors to Assess Rare Multi-System Illnesses. Heather, tell us some of the take-home messages that you want the KevinMD audience to come away with.
I think the main one is really simple. Listen curiously to your patients and believe what they tell you.
Heather, thank you so much for sharing your story, time, and insight. Thanks again for being on the show.
Thanks for having me.